Our next speaker is Michele Lambert, is a pediatric hematologist and associate professor of peds at Children's Hospital in Philadelphia, or CHOP. Michele completed her undergraduate degree at Rensselaer Polytechnic Institute and her medical degree at New Jersey Medical School, which is now Rutgers University. After further clinical training, she landed at CHOP to complete her pediatrics, adding on a master's degree in translational research at the University of Pennsylvania. Michele is an international force in the field of childhood bleeding and a leader and advocate in pediatric ITP and platelet disorders, and we are pleased to have her present today. And I'm not sure why. Let's do it. Okay. So there's your notes.
Cool. Okay. Awesome. Excellent. Cool. Thank you for that introduction, and thanks for inviting me to come up here and enjoy the beautiful sunshine. I'm going to change directions a little bit, and with a caveat that I'm also a veterinarian for a single species, which is humans. And I will be talking about a little bit more clinically related research. So, all right, let's see if we can move this forward. I do have some disclosures. All right, so I'm going to talk about potential impact of genetic evaluations on patients with suspected inherited and acquired platelet disorders, and looking at the role of genetic testing in patients with platelet disorders, because that's kind of what I do, and taking it both from the clinic back to the lab and from the lab back to the clinic, and kind of going back and forth that way. So platelets are really not that simple. We used to think that platelets had a major role in vascular integrity and hemostasis, and that was primarily all that they did. But now we know that they have roles in a lot of different parts of angiogenesis and development. They have a role in tissue repair and inflammation, and we just had a beautiful talk about megakaryocytes even, and potentially a role in the inflammatory response. So an important acquired platelet disorder is a disorder called immune thrombocytopenia. This is an acquired thrombocytopenia in which patients developed an autoantibody response to platelets. And it's not entirely clear why this happens in patients. In pediatrics, the thought is that it's essentially a loss of tolerance, and the majority of children eventually figure it out. Their immune system sort of resets itself and rights itself. And in about 80 to 90% of pediatric patients, it goes away between 3 and 12 months from diagnosis. So we call patients with ITP newly diagnosed if it's lasting for less than 3 months, persistent ITP if it's between 3 and 12 months, chronic ITP if it's lasting for more than 12 months, and less than 20% of pediatric patients develop chronic ITP. But on the adult side of ITP, over 70% of adult patients who develop ITP develop chronic ITP. So it's a very different disease, but probably a very similar mechanism of development. And so it's really interesting to look at how different the immune response is in the pediatric patient and the adult patients, and trying to sort out why those differences exist has been really interesting. We used to talk about severe and refractory ITP. Those definitions are changing and probably are going to be a little bit different than they currently are, mostly because these definitions are a little bit impractical and hard to use. So we're not using those so much. But clinically, ITP in pediatric patients at least presents with a severe thrombocytopenia in the vast majority of kids, very, very low platelet counts, usually less than 20,000, less than 10,000, all of the sudden, and patients are suddenly presenting with bruises that are very unusual and very different for them. So this is a child's leg, and these bruises are on the upper part of the leg, and this bruise actually was a palpable bruise. You could actually feel a knot under the skin, and that's really quite unusual. Most people don't bruise like that. The thing that scares everyone about ITP is this potential complication, and this is a CT scan of the brain, and here is an intracranial hemorrhage, and everybody is terrified of this potential complication of ITP, and so everyone is really scared of that very, very low platelet count, because when platelet counts are less than 10,000, that is permissive for intracranial hemorrhage, although it's not the only thing. And most patients who have these very low platelet counts will never do this. It happens in less than 1% of patients who have very severe thrombocytopenia, but it does happen in some patients, and trying to figure out who's going to do that is a large focus of what I've tried to do in my research. It happens in about 1 in 20,000 children per year. So the prevalence is about 1 in 12,000 children, and the median age at presentation is around 5 years of age. So these are young children who are doing this. And as I said, most children get better spontaneously in the first 6 months, and the vast majority actually are better by 12 months. Trying to sort this out, because these are young children who are presenting with very low platelet counts from the inherited platelet disorders, can be tricky. And it's been something that has been a focus of the work that I have done, is trying to say, okay, well, so I have this patient who presents with a low platelet count. Have they always had a low platelet count? Is this something that they were born with? Do they actually have an inherited thrombocytopenia? Or is this ITP? And we know that platelet disorders are pretty rare, and the inherited thrombocytopenias occur probably, classically we're taught about 1 in 100,000 people. Platelet function disorders are probably more common than that, and probably about as common as von Willebrand's disease is. And those homozygous defects like Glanzmann's thrombasthenia and Bernard-Soulier syndrome that are pretty well studied and well understood as far as the severe platelet disorder goes are really, really rare, and those are generally homozygous defects that are inherited as autosomal recessive disorders. So these platelet disorders, differentiating them from the acquired platelet disorders, sometimes requires genetic testing. One of the things that we looked at was to try to understand, well, how rare really are the inherited platelet disorders, and particularly the inherited thrombocytopenias and platelet function disorders. So we looked at NOMAD, and we looked for loss of function variants in platelet disorder genes. So we looked to see, first of all, are there loss of function variants, and are there variants in genes that are expected to cause loss of function that are reported in NOMAD. NOMAD is a large database of exomes that have been collected over time, and this large database is supposedly healthy people, and so these should be people who don't have diseases. But what we found was there's actually a significant number of individuals in NOMAD who have what are predicted to be loss of function variants in some of the inherited platelet disorder genes. And so we actually found that the estimated frequency of loss of function variants in the general population was closer to 1 in 3,000 individuals for the inherited thrombocytopenias in particular. And so we're probably missing inherited thrombocytopenias, and we're probably misdiagnosing them. So the prevalence of platelet disorders is maybe higher than we think that it is. And for this reason, I think there's been a bit of a push to do more sequencing, even in patients where you think you know the diagnosis. So to illustrate some of the benefits of genetic testing in patients, this is a patient that I took care of. Ignore the case 6, it's actually the first one I'm talking about. But so he presented initially at 5 months of age. He had acute SARS-CoV-2 infection with fever and petechiae. And this is the first time he had a CBC done, and at that time he had a platelet count of 14,000. And they did the CBC because he had the petechiae. He had a hemoglobin of 10.7, which in a 5-month-old is a little bit low, but not terrible. A normal MCV, and a white blood cell count of 7, so and a normal neutrophil count, normal-ish neutrophil count. And we attributed the low platelet count, the mildly low hemoglobin, and the mildly low neutrophil count to the acute infection. He was acutely ill, and we figured this was viral suppression. But a week later, his platelet count was a little bit better, it was 44. His neutrophil count now was only 100, though, so that dropped even lower. So we repeated his counts again a week later, so now he's had 3 counts, and his neutrophil count was better, so up to 1,200, but his platelet count was back down to 17,000. Throughout all of this time, he was never treated for that low platelet count, and he continued only to have some bruising and petechiae, and he didn't have any other bleeding symptoms, no nosebleeds and no mouth bleeding or anything like that. We can measure essentially what is a platelet reticulocyte count. It's called an immature platelet fraction, and that immature platelet fraction was between 5 and 6%. So not markedly elevated. That's actually a quote-unquote normal immature platelet fraction. So it's low for a platelet count of 14,000, because you would want to see that that is increased in a patient who has a low platelet count. So we thought maybe he was just struggling to recover from his virus infection or getting back-to-back viral infections, as many little babies who are in daycare get. But over the next 12 months, he continued to have platelet counts that were in that 15 to 20,000 range, and he developed an iron deficiency anemia that responded to iron therapy. He was breastfed, so maybe he had a reason for his iron deficiency. But about 12 months into this diagnosis, he presented with an unexpected sudden hemoglobin of 7 and a reticulocyte count of 0. So now his red blood cells were not responding to his anemia. A platelet count of 5, so even lower still, with an immature platelet fraction of only 1%, and a neutrophil count of 1230, so still was making white blood cells. So he was actually admitted to the hospital. At that point, we did a bone marrow, and he was profoundly hypocellular. So had normally a bone marrow in little babies actually looks mostly like this. It's really quite cellular. In an 18-month-old, a bone marrow should be about 80% cellular, and his was 80% not cellular. And he actually had a distinct lack of megakaryocytes in his bone marrow. There's only one visible on this field. And I think that was actually the only one we saw on his entire biopsy. And so at this point we thought, this doesn't look like viral suppression, this doesn't look like ITP, and we did genetic testing. And his genetic testing returned a homozygous pathologic variant in MPL, so he had congenital amegakaryocytic thrombocytopenia. And he actually underwent a bone marrow transplant, or actually a hematopoietic stem cell transplant with an unrelated donor, because he's the first affected child of this couple, and is now 4 months post-transplant doing really well with a platelet count of 293 and a normal neutrophil count. His hemoglobin's still on the low side, but and his immune system is beginning to recover. So this is a case of what was thought to be ITP and turned out clearly not to be. And studies actually suggest that in about 15% of patients, we're wrong about ITP. And in about, and it turns out to be something else, and that's in adults. And in about 3% of patients where we think it's not ITP, it actually is. And emerging data suggests that a significant portion of patients who have immune thrombocytopenia actually have secondary immune thrombocytopenia, not primary. And the pathophysiology of this disease is quite complex, and we have learned that every part of the immune system likes to get involved in ITP, and so we used to think this was purely a humoral response. Last night at dinner, we were talking about the classical Harrington-Hollingsworth experiment that showed that it was a humoral response, but we know now that actually T cells get involved, and I actually wonder after Craig's talk if maybe the lung megakaryocytes are doing something or not doing something that they're supposed to be doing, especially since TLR2 and TLR7 have been shown to be related to development of ITP. So I wonder if there's a link between the lung megakaryocytes and ITP, but we can talk about that later. So, and not even kids who develop ITP are not always just ITP. So, I took care of another patient who at 6 months presented with bruising and petechiae with no family history. He was diagnosed with ITP and responded beautifully to IVIG. He had a platelet count of less than 10 at diagnosis. He got his IVIG, and a week later, his platelet count was totally normal, 300,000. But after 4 weeks, his platelet count decreased again. Since he had no symptoms, we decided not to treat him. At 11 months of age, he developed autoimmune hemolytic anemia. This is now a second immune cytopenia. Something's not right here, because now his immune system got confused twice in an 11-month period. And while everybody's allowed to get confused plenty of times, the immune system's usually not that bad. And while we were weaning his corticosteroids, he actually relapsed with his ITP. So now he has relapsed ITP, which less than 10% of children develop. And he had autoimmune hemolytic anemia, and then he developed neutropenia as well. And so he's now had an immune system that got confused an awful lot of times, all related to his blood cells. And so we thought there must be something else going on with him. He actually also continued to develop intermittent thrombocytopenia pretty much every time he got sick. So every time he got an ear infection or an upper respiratory infection, he would drop his platelet count. So every time his immune system was responding to something, it would also respond to his platelets. He got ear tubes placed, and this got his ear infections got much better, and he had fewer flares of his hemolytic anemia and his ITP when we fixed his flares of infections. An immune evaluation at 4 years of age actually showed that he had low immunoglobulin levels, normal B cell numbers, poor vaccine titers, and a poor response to a pneumococcal boost, and this is classic for common variable immunodeficiency. And so he actually had CVID, but most kids don't get CVID. That's actually usually an adult diagnosis of immune dysregulation. We started him on an immune modulating agent called sirolimus, which is an mTOR inhibitor, to try to stabilize his immune cytopenias, and this actually worked really great, except that now his IgG levels were really low and he wasn't responding to vaccination, so he also needed to get supplemented with his with sub-Q immunoglobulin. So his parents asked me, why did my kid develop this? So we decided to look and see if we could find a genetic reason for it. And he had a clinical whole exome, which was negative, and we did some targeted testing, because sometimes an exome, because it's so broad, will miss some of like intronic mutations or other things like that. And so we decided to do targeted sequencing for a lot of particular genes, and that was also negative. So we got permission to look at his exome on a research basis. And we found a variant in a gene called REL-B, and REL-B is a transcription factor in the NF-kappa B family. And if you have two variants in REL-B, it causes an immunodeficiency that presents with early infections, impaired T cell proliferation, an increased CD4 to 8 ratio, and an impaired specific antibody response, which kind of looks like CVID. In other words, you can't respond to immune stimulation and you can't make antibodies well. This was de novo in him. His parents didn't share the mutation. It wasn't previously reported. It doesn't exist in databases of healthy patients. And it's in a conserved residue predicted to be damaging. So we thought, well, this is interesting. So we looked at his immune system a little bit more closely, and he actually meets the immunophenotype of a patient with a Rel B deficiency, except he only has a single variant. But he really looks like a Rel B deficiency, and we actually diagnosed him with Rel B related an inborn error of immunity. And in collaboration with a couple other immunologists, we now put together a case series of several patients who have single variants in Rel B that sort of have an autosomal dominant effect and cause decreased expression of the other gene. So immune dysregulation in ITP, we wanted to see, is this something that happens pretty commonly? We looked at our study population, or patient population at CHOP, which was about 1,000 patients over 20 years. And the majority of those patients have ITP. Evans syndrome is 2 cytopenias or more, which is what that last patient had. And most of the patients have a short duration of their ITP. It gets better in 2 months or less, but there are some patients who have very long duration of their disease. And what we found was when we went back and we looked at what happened to our ITP patients, even those patients who got better but continued to be followed at CHOP for other, like by their primary care physician or whatever, we found that some of those patients who had ITP later on went on to get other diagnoses like lupus or a diagnosis of ALPS or CVID. Some of the patients eventually developed Crohn's disease or other immunodeficiencies. And what we found that in over half of our patients who had ITP, whether or not they resolved their ITP, they had some other underlying immune problem that developed. Chronic ITP was associated with an increased risk of developing that or having a relapse of your ITP, having other features of autoimmunity, like having Evans syndrome, for example, or family history, was a clue to this immune dysregulation, but not every patient had that. And it matters because I think if you know your patient has an immunodeficiency or has Crohn's disease, you're going to treat them differently than if they just have ITP or has lupus or something like that. It also can inform the management of family members, particularly if you identify a genetic cause, because you might screen those family members. So the last patient is Bryce, who's a 17-year-old who presented with nosebleeds after wisdom tooth extraction. His platelet count was normal, with normal appearing platelets, a normal immature platelet fraction, normal platelet granulation by light microscopy, a normal mean platelet volume. Platelet function testing, though, demonstrated abnormal secretion to ADP and low-dose collagen with normal aggregation. So we did platelet EM, which demonstrated a dense granule deficiency but not complete absence. This was a totally otherwise normal 17-year-old. And genetic testing on this patient, because the parents insisted upon it, and he really wanted to know, demonstrated a pathologic deletion in RUNX1 that's been previously reported. Well, now we have a cancer predisposition syndrome, because RUNX1 is a familial predisposition to leukemia syndrome in addition to a familial platelet disorder. And so this patient, we went back and we asked more questions. And it turns out actually that the family doesn't talk about it, but there's a maternal uncle who died of leukemia, and maternal grandfather was recently diagnosed with MDS, but the family doesn't actually talk about that because they don't want anybody to worry about it. And when we did the consent for the genetic testing, we talked about the fact that we could find a cancer predisposition syndrome. So now we've found one, and we said, And there's a high probability, Mom, actually, that you have this. Actually, the probability that you have this is essentially 100% based on that family history. Do you want to be tested? And Mom said yes, so we made the diagnosis, and Mom had a bone marrow, and her bone marrow actually showed a genetic change in a second gene that is associated with an increased risk of developing MDS. So she was referred, and I don't know actually if they decided to preemptively talk about whether or not she needs additional therapy. But in her case, I think potentially may make a difference in her outcomes. So genetic testing can help differentiate causes of platelet dysfunction and thrombocytopenia in patients with atypical presentations or family history. It's really important. And not all thrombocytopenia is ITP, and not all ITP is primary. So with that, I'll thank all the people that have worked with me on all of this, the patients and the families who participate in all of this work, as well as my collaborators and my teams.
Just wondering if there's ever been any effort to prospectively sequence a cohort of ITP patients just to see how deep this problem runs.
Yeah, so it's hard to get that funded. We've been trying. We have DNA prospectively collected on a group of ITP patients, but it's actually hard to get anybody to pay for that study. Most of the time we end up just sequencing clinically when they hit the chronic stage, and especially if they have other things that make us suspicious.
Hi, Jose Lopez from Bloodworks Research Institute in Seattle. I have a question about Joseph. Does the CAMT diagnosis explain why he showed up anemic with a 0% retic count?
Yes.
It does?
Yeah, because in a percentage of those patients, they actually develop true bone marrow failure, which is essentially what he had progressed to.
It looked like bone marrow failure,
Yeah.
Thank you.
Mm-hmm.
I'm also wondering about Joseph and thinking he came in with COVID. He's got petechia, persistent issues. I'm wondering whether he was tested for some sort of other transmissible problems, maybe vertical transmission. I'm thinking something like zoster, which is consistent with hearing loss and petechia and these sorts of things.
Yeah, so he actually, part of the reason it took us so long to take him to do a bone marrow and everything like that is he really had back-to-back infections. So he had COVID. He actually recovered and cleared his PCR. He then had rhinovirus. He then had influenza. He then developed, he was well for a period of time. His platelet count actually came up to like 30,000 and hung out there for a little while without any treatment or anything. And then the winter came around again, and then he got COVID again. He got influenza again. He got parainfluenza, and he got croup. So I think it was like it took us a while to get to the point where we ended up doing a marrow on him, in part because we kept attributing, especially the low immature platelet fraction, to the fact that he was, we thought, intermittently suppressed.
Poor little guy.
Yeah.
Wonderful talk. Quick question, when those patients get to that chronic stage and we're thinking about doing those genetic testing, wanted to get your thoughts on some of those, panels that are out there that you can use versus whole exome, and your thoughts on that.
Yeah, I usually start with a panel, in part because the sequencing is deeper usually with panels, so you get better coverage a lot of times, and because I I rather only ask a question that I want to know the answer to. So if I'm looking for an inherited thrombocytopenia, I rather do a inherited thrombocytopenia panel and really ask that question. Or if I'm looking for an autoimmunity predisposition, I don't know that I want to look for cancer predisposition and get back RUNX1, right? So I try to target the testing, and only if I'm really worried that this is an inherited condition and I haven't found an answer, will we then expand and go to exome? Or if the family's really interested and they want to do research testing, then we'll move to research exomes and things like that. But and then, with full consent, recognizing that we may find out things that you don't want to know, like, that you also have Duchenne's, or that you also are not your father's child, and things like that. So yeah, all that kind of consent becomes very complicated. And
hi, Mark Bellatruti, Peds Hematology here at Children's. Thanks for highlighting our daily clinical struggles with these with these patients. I guess my question is, how do you resolve or deal with the inevitable VUSs that always show up? And just what's interested to hear your approach to that.
Yeah, I mean, first of all, I'm very, very lucky that I have a lot of friends and colleagues and resources that can try to help me to evaluate those VUSs. So I work really hard to try to push a VUS one way or another, and have a lot of resources available to me to be able to try to do that, like that patient with the Earl W, where we were able to partner with a group of other immunologists to with our immunology group to immunophenotype him, and then also with other immunologists to look at the function of that particular variant in immune cells. I think it's harder when you don't have that kind of network, but those networks are out there, and I think the best thing to do is just ask. The Society for Clinical Immunology Society has a board that you can post questions to. ASFO has a board that you can post questions to, and so I would just say, hey, has anybody seen this variant before? And that's the only way we're going to learn which way they go anyway. So.